Good afternoon, everyone, and thanks for joining. We're going to let everyone continue to log on, and we will get started in a couple of minutes. All right, it is 3:01, so let's go ahead and get started. Hi, everyone, and thank you for joining today's webinar. This will provide an update on provider relief funds and healthcare industry focus from a regulatory compliance perspective. Today's program will be presented by Domenic Segalla, market leader, and Marc Stein, principal in Withum's healthcare advisory team. Before we begin, I have a few notes. Today's materials can be found in the toolbar on the right of your screen. Also, on the bottom of the toolbar, you will see a chat box. Feel free to send us your questions during the presentation. We'll do our best to address them at the end. There will be 4 polling questions throughout the program. To qualify for CPE credit, you must participate in each poll. CPE certificates will be emailed to you within a few weeks. And finally, once the webinar is over, there will be a pop-up asking you to complete a survey of today's webinar. Please take a moment to complete it. It is our way of being able to provide you with the best and most relevant programs possible. With that, I'm going to turn it over to Domenic.
Thank you, Rachel, and welcome everybody to today's presentation. My name is Domenic Segalla. I'm the market leader here at Withum, and we have a lot of information to cover today. Our goal is to spend probably 40 to 45 minutes talking about our presentation, high-level update of the CARES Act, talk a little bit about the advanced Medicare payment. I want to focus on the 11521 post-payment notice, as a lot of changes came about from a reporting standpoint for the provider relief funds. Then I'll hand it over to Marc Stein, who's going to talk about the compliance risk and best practices that we see from our clients in relation to the provider relief funds and other portals of funds within the CARES Act. And then we want to leave 15 to 20 minutes for questions because, you know, as we go through this on a daily basis, it continues to have a lot of questions, a lot of changes, many updates from HHS. So it's an evolving as we continue to learn more. So we assume a lot of questions, and then if there's time, we can give an update on the new stimulus bill, what we're hearing out there from the industry, and what we think it will contain. So with that, let's get started. So everyone's aware of what the CARES Act came out almost a year ago. I can't believe it's been a year now. And really, what I call it, it was the lifeline of cash flow for providers to enable them to continue to provide care. None of us knew what was going to happen at that point in time. The government acted quickly. They put into play the Provider Relief Fund for economic support. And since then, they've actually issued $140 billion, almost $145 billion of money was one piece of the CARES Act. The second piece, and a lot of people forget about it, but they will be remembering because it is a loan and it needs to get paid back, was the Accelerated and Advanced Payment Program. That Medicare, basically, you are allowed to receive up to 6 months of your Medicare reimbursement as a loan to, again, add a lifeline of cash for all the providers out there. Next slide. So Medicare Accelerated Advance Payment Program, again, put into place as a loan that was sent out there. One thing I would like to note on this, in the Consolidated Appropriations Act and in the current bill, there was language for forgiveness of up to 45% of the Medicare loans that are starting to become due. We don't know if that's going to make the final cut. It did not clearly in the December 27th Consolidated Appropriations Act. We're not sure if it will make the cut in this one either, but clearly there's a lot of lobbying effort out there because there's over $100 billion that providers now have to start to pay back, which will only put more of a strain on the cash flow for all of the providers. Next slide. So the first polling question.
How many months?
Oh, sorry. Go ahead, Reed.
How many months do you have to pay back the Medicare advance? All right, about 20 more seconds. All right, I'm going to close it out. And here are the results. Like about 45% of you said 12.
And thank you, Rachel. And that's really what I assumed, as there's been a lot of confusion around this. And if you could go to the next slide, Rachel. And here's the takeaway from this slide, 29 months. That's a number I want you to remember, and we'll go through it quickly. So initially it was supposed to be paid back within 12 months of when you received it. Now there's a 29-month period. So you get 12 months from the date of when you received it, let's say March 1st of 20. So you have 12 months of no payment to March 1st of 21. The next 11 months, Medicare will then recoup 25% of it. So if you received $1 million in the 11 months post the 12-month, they would take back $250,000 over that 11-month period. 12 months plus 11 months is 23. The next 6 months subsequent to the 11 months, they would then take back 50%. So the 12 plus the 11 plus the 6 is 29 months. After the 29 months, simple interest is calculated at 4%. And there's some talk about lowering that. But the thing to take away here is, if you still have money due at the end of the 29th period, 29 month, you are not paying compounding interest throughout the whole period. It would start day one after 29 months at 4%. So again, 29 months you have to pay back. Many of you, the 12-month period will be coming up soon, so you should build into your cash flow forecast over the next 11 months is 25% recoupment. Next slide. I just like this slide. Again, we all know the funding that came about. I think there's three important things on this slide. One, the $24 billion, if you see the yellow highlighted, that came out in phase 3, we'll talk about that. Those payments started distribution on 12/16 of 20, and they're, from our understanding, fully distributed. The second important thing I spoke about was the total appropriated funding of this, $175 billion, and the remaining $25 billion that has not yet been released. And we'll talk about that because there is language that came out in the Consolidated Appropriations Act that has some opportunity for more funds to come out. Next slide. So just one quick thing here. Everyone understood they had to sign an attestation. There's terms and conditions that applied to all of the funds. There was a 90-day period if you wanted to keep it. And we did have a few clients that called us and said, you know, we've never taken care of a COVID-19 patient. I don't think we can keep it. In the language, it actually says possible, and any patient can possibly become infected with COVID-19. So just a little clarification there as something that we were hearing, even in terms of the phase 3 receipts. Next slide. So here are the 3 words I want you to remember: prevent, prepare, and respond. So when it comes down to how to utilize these funds, it's to prevent, prepare for, and respond to the coronavirus. and the pandemic. So if you can remember that from an expense standpoint, that's what you think of. What funds did I utilize to prevent, prepare for, or respond to coronavirus? Next slide, please.
Okay, we're on to our second polling question. When is the reporting due date for provider relief funds? About 15 more seconds. I'm going to close it out. And here are the results. It's like 64% did TBD.
And that's great, thank you, Rachel. And that's actually the correct answer. The initial reporting was February 15th. Clearly that's past us now. As the new phase 3 money came out, there was no way they could continue to have the reporting date as of 2/15. What we believe will take place is we think the reporting deadline will be sometime, we actually think it's going to be July 31st, will be the new TBD. And the reason for that is those of you that received funds in 2020 and could not utilize all of those funds, and we'll go through the two-step process, the expenses applied, and then the lost revenue, the remaining balance of those monies can be carried over to the first 6 months of this fiscal year. So you have until June 30th. The phase 3 and the carryover reporting deadline is 7/31. So we believe all to coincide, all of the other tranches of provider relief funds will also be due on 7/31. Next slide. So phase 3, we talked about that a little bit. Phase 3 was different. You had to apply for and submit data for phase 3. The first few tranches that came out were based on cost reports, and then there were target specific tranches based on COVID-19 discharges, etc. Phase 3, though, released about $24.5 billion. As I stated, it started on December 16th. It was a little bit different, though, and it's been confusing. And I'm going to give a few examples. And in retrospect, I probably should have gave some examples here, but I'll verbalize them, of the calculation they used, because a lot of our clients were confused as to why they did or did not receive money in phase 3. But the goal of phase 3, if you see the bottom highlighted area, was to get all providers, and it was more specifically around the Medicaids, the not-for-profits, those that did not file cost reports or did not have target impact, to get all of them up to, at a minimum, 2% of their 2019 net patient service revenue. Next slide. So, and here is where the confusion took place. So it was the greater of 2% of your net patient service revenue, or 88% of your losses that you submitted, which was your Q1, Q2 of 2020. So I'll give you an example. Let's say you're a $100 million operation. 2% would be $2 million. You received $2.4 million prior to phase 3. So you already hit the 2% threshold. 88% of your Q1 and Q2 losses were $600,000. So even though you submitted all that data, you would not receive any more funding. In that same scenario, $100 million operation, $2 million is your net patient service revenue. Let's say you received $2.2 million again, but your first and second quarter losses were $3 million. They would take the 2.2 that you received, even though it was in excess of the 2%, and bring it up to your 88% of losses. So it was the greater of the 2% or the 88% of your submitted losses for Q1, Q2. A lot of confusion around that. And there was also money that went out to the nursing homes on top of just the acute care side. Next slide. So the other thing with phase 3, reporting requirements, attestation, mirror prior distributions. Same thing with the use of funds, comply with all previous disclosures for the provider relief funds. And as I stated, tentatively, we believe phase 3 will be a reporting deadline of July 31st of 21. So there's still some time. So I just wanted to go over this because there's still a lot of confusion. We still work with our clients on this. It's a two-step process. First, you have to look at expenses that are attributable to the coronavirus. The key here, again, prevent, prepare, respond to, but the other big issue is it cannot be double counted. So if you use salaries for PPP or if you use supplies for FEMA grant, you cannot utilize those same expenses again for the provider relief fund. After you've exhausted what expenses you can use, you then look to the definition of lost revenue, which there's been a lot of confusion on it, but we'll clarify it for you today. Next slide. So from a reporting standpoint, anyone who received over $10,000 in provider relief fund will have to report. Anyone who received between $10,000 and $500,000 can report their expenses from a general and administrative. So these are the categories that they will report on. Over $500,000 we'll show you in the next slide, but these are the high level areas. Again, any of these where you can apply where it's prevent, prepare, or respond to the coronavirus and the pandemic. That's a type of cost that you can use. Next slide. So those of you that receive greater than $500,000, you'll have to get into more detail into the supplies. And again, common knowledge here, but clearly you want to treat this as an audit. You want to have supporting documentation. Equipment. You know, we had a client who purchased $1 million piece of equipment for their laboratory just for the COVID-19 testing. That clearly meets this definition. IT, expansion of telehealth. IT consultants, the software, the hardware to go with that, so you could continue to provide service, that qualifies. Facilities, you know, expansion of your ED or additions put on to set up urgent care or renovations to your ICU, converting other rooms back into COVID-19 rooms. So all of that counts towards the expense definition. And there's some leeway here. So for those large corporate systems that are on, there are the ability, as long as you have a methodology and you can support it, for corporate allocation and allocation of costs. And also the bottom right here box, you know, even to the point of, and this is right from HHS, length of stay related expenses. So if you had problems because of the post-acute situation and you couldn't get your patients out, and you could come up from your cost report with what's that cost per day is for that patient staying in your institution, you weren't receiving reimbursement, that also counts. So there is leeway, you just have to have support and a methodology behind it. Next slide. This, if there's one thing you remember from this presentation, please take this down. You need to go to the link that I provided here. HHS has provided frequently asked questions for provider relief funds. I actually counted them today. There's 124. They continue to update them. Last update, I think there was in the end of February, there was 3 new updates that came out, which supersedes other areas. And it's based on people continuing to ask questions. So further clarification, I go back to it all the time. It's easy to use because it actually notes the date that it was updated. So if you go through it, it's a very helpful tool. They give the answers on there. We use it all the time as guidance, and it really points you in the right direction. A lot of stuff around corporate, a lot of stuff around targeted distributions, around larger systems, who received the money versus who has to report on it. So a great resource guide, and use the link that's provided right here. Next slide. So on December 27th, former President Trump signed in the Consolidated Appropriations Act. A few very important things came out of this. One, there is $3 billion more of provider relief funds that will be distributed. As of now, we believe it's going to be distributed on Q3, Q4 of 2020 data. So it's going to mirror that of phase 3. You're going to have to apply for it. The second piece that came out was the new definition for lost revenue, and let's hope it's the last one because there's been about 5 of them. The other thing it allows for is targeted distributions to be reallocated. So for the larger systems that are out there, we had a client with 2 urban hospitals who received targeted distributions because of their COVID-19 discharges. Other hospitals who were struggling in the rural setting did not receive those funds. What this allows you to do now is to reallocate those funds. Prior to that, you could not. So it can be pulled up to corporate and redistributed amongst the hospitals within your system, so it can help those in need that did not receive the actual targeted distribution. And there's also some language in there of some possibility of unspent provider relief funds, and we'll talk about that a little bit more. The last piece, which could be a whole hour presentation, I'm not even going to get into it today, the surprise billing ban. But I'd be remiss if I also didn't note, very important, each one of you should go back to your advisors, accountants, because what also came about in this is the employee retention tax credit. And I know we're not talking about this today, but this is free money. For those of you who had under 500 FTEs and had a PPP loan and could not qualify, you now qualify. For those large hospital systems out there or any physician provider group, because of the partial government shutdowns, they vary by state based on jurisdiction, you also qualify. Please go back to your advisors, go back to your auditors, or come to us. This is free money, the Employee Retention Tax Credit. Changes came about in this Consolidated Appropriations Act. Next slide. So here's the important thing, another important takeaway. And I'm not going to read the language, everyone can read this, but basically the language that was contained within there basically says any unspent dollars, and this is why I highlighted on slide 3 or 4 that there's still $24 billion left, although the number changes. It was 34 billion in December, now it's 24. All of those unspent funds, along with any funds that are sent back, so many of the larger systems are sending dollars back, there will be a process, just like phase 3, where those funds can be redistributed up to 85% of losses based on Q3, Q4. So phase 3 funds was at 88% and it was Q1, Q2. There is language in here, if they move forward, that allows those unspent funds to be sent to or distributed to those providers that qualified based on Q3, Q4 losses. So some good news here. Language is in there, now we'll just have to see if it's moved forward. Next slide. So the 11521 post payment notice, this was critical for 2 basic things. The biggest being the final definition of lost revenue. The second is it allowed for the portal to be open for HHS. This is not from a reporting standpoint, you can't go and report yet, but it's a registration. We went through the process, it takes about 20 minutes. It asks basic questions, but the key takeaway here, if you have not registered, make sure the email that is submitted is the email of the person that will be responsible for this. We did have a client or 2 who the higher up put in an email address, and now as information's coming out, they're not getting the email forwarded to them from HHS. So the person who will be doing the reporting should have their email address in there, because when HHS is ready to open up the portal for reporting, the person who registered and that specific email address will get the information. So that's important to know if you have not already registered. Next slide. So lost revenue. So here's the confusion, right? Back in August, actual versus budget makes sense. September 19th, I'm not even going to comment because we had absolutely no clue what they were talking about. October 22nd, then they came out and said, okay, maybe we should have actual versus actual year over year. That made sense to us. December 21st, when the Consolidated Appropriations Act, then they said actual versus budget, resorting back to what they said first in August. Next slide.
Okay, we are on to our 3rd polling question. What methodologies can be used for calculating lost revenue? Right, about 15 more seconds. All right, I'm going to close it out. And here are the results. Looks like 58% did all the above.
Great. And if you could go to the next slide. Thanks, Rachel. And I remember back in, grammar school, high school, I used to think that D, all of the above, was a trick question, but that was the right answer. And here's what they did. So they basically said, whatever is more advantageous to you, you can use actual versus actual, you can use budget versus actual, with a caveat that your budget had to be approved by March 27th. For physician groups, it would be an attestation from the owner, director, CEO, if an actual budget was not put in place. And the third one, and we don't recommend, but they do allow any reasonable method of estimating revenue, and there could be a good reason for it. We just think it opens up an opportunity for them, being HHS, to come in and take a look at this methodology. Next slide. So just to pull everything together, a few important takeaways. I talked about prepare for, prevent, or respond to. I talked about the importance of going to the HHS website, and it's under FAQs. Even if you just Google Provider Relief Fund Payments FAQs, a lot of great information. And here is just a summary of reporting of expenditures. So as we said, we believe all of those tranches of money that came out in 2020, along with phase 3, will be 7/31. Any of those funds that were not used at the end of 12/31/20 are also carried forward, and we believe those also will coincide with this 7/31/21 reporting deadline. Please reach out to your advisors. This is changing all the time. With $140 billion of money being distributed, clearly the government, HHS, come back and take a look at this. So you want to make sure you have everything buttoned up from a documentation and support, and make sure when you do your reporting, you're complying with all the current regulations. So with all of that, I'm going to turn it over to Marc Stein, who will take over from here and talk about the compliance side.
Thank you, Dominic. I'm going to, Dominic provided the update of the CARES Act and provider relief funds. I'm now going to discuss 3 programs under the CARES Act and provider relief funds, which are compliance related, which we all should be concerned about as far as documentation and keeping and testing, make sure it's in compliance performance. We talked about lost revenue methodology and calculation. We'll get back in a little more about that. The uninsured program, it's a very important, so a lot of money's been spent, given to providers, so we're concerned about being compliant and being audited. HHS is going to come back and audit this area, and also the 20% add-on for certain DRGs as far as for the COVID-19 treatment. So we're suggesting we see our clients utilize internal audit to ensure compliance with these programs. Next slide, please. Okay, this slide is just a summary of overall compliance monitoring best practices. It covers those 3 programs, but it's just more general. The first one is develop reasonable methodologies for calculating lost revenues. Dominic's talked about that. We're going to give an example of that in a couple minutes, but can't stress enough to make sure the components are consistent with the language as far as actual versus actual, actual versus budget. Develop mechanisms to identify and track COVID-19 related expenses. As Dominic spoke about the expenses, as far as, then it's very important to document this and keep track of that. Develop policies and procedures and standards regarding necessary documentation to support the use of funds. This will be important, as HHS will come in and scrutinize and audit you, so it behooves you not to have these set up in advance. The next item is establish an infrastructure tracking all these. I'm sure everybody's been doing that, but just make sure it's tested and it works. Developing monitoring plans to mitigate funding compliance risks, such as audits around balance billing. We'll talk about balance billing and the uninsured, but also use of funds for excessive physician executive salaries. There's limitations of dollar amounts you can use to be applied in this as healthcare expenses. And last, monitor and communicate newly published regulatory guidance, applicable stakeholders. As Dominic mentioned, it's constantly changing. And we provided some websites and things. So I guess you need to keep, because it's going to, based on what's happened up to now, we've not seen the end of all the changes. Next slide, please. Okay, this slide is similar to what was presented before. We felt the need just to really to make sure everybody get their takeaway as far as the different methodologies you can use, as far as between the 2000, the calculating lost revenue, and as Dominic mentioned, there's actual versus actual 2019 versus 20, and there's a budget versus a budget as far as 2020 versus 2020 as far as actual versus budget. And the third method, the reasonable method, we're sort of not recommending because that's going to cause a lot of commotion as far as if you're a provider and you choose that approach. So next slide, please. We just want to just relay the importance. If you're going to go the method with the budget versus the actual for 2020, it must be established and approved on or before March 26th. It must be, the physician group must be ratified or certified by the reporting entity's financial executive as of that date, and there has to be attestation that the budget was established, approved on or before March 26th. This is very important. There's documentation to support this, as HHS will be looking for this information, and we need to maintain this. Next slide, please. Dominic's going to go through the lost revenue example for you right now.
Yeah, thanks, Mark. So, I said prior I should have put an example, and examples are always great just so you can go back and look at it again. So the assumptions we put in the left-hand box: provider relief funds received of $1 million. In this example, there were $400,000 of expenses, not double counted, that could be applied towards the provider relief funds. So there was $600,000 left to be applied towards the lost revenue calculation. So we have two columns here. The first one being actual versus actual. So option A, there's 20 million of actual patient service revenue, 20.2 million in 2019 of actual patient service revenue. So if you're using the actual versus actual, that gives you $200,000 of lost revenue. Now that 200,000 doesn't get you where you need because you needed 600,000. So now you look at option B, right? Again, 20 million of actual in 2020, but instead of comparing to 2019, we're going to compare to 2020, where the budget was 20.7 million. And assuming it was approved by March 26 or attested by the owner, director, manager, that creates a $700,000 loss. Clearly, in this scenario, the $700,000 gets you to the unapplied funds of the 600,000. If, for instance, you only used option A, you would have to return $400,000 back to the government. The objective of this is to maintain and keep all of these funds. So we thought just a good example to be able to look at so you can share with your team. Thanks, Mark.
Thanks, Dominic. Next slide, please. So, lost revenue calculation methodology, best practices. Well, since we recommend, we've seen our clients that internal audit should be utilized and involved in this methodology and calculation to make sure it's consistent and it works and there's documentation for it. And also the 2000 budget is utilized to make sure it meets all the applicable criteria. Can't stress enough that this area will be scrutinized by HHS, and documentation and methodology is very important. Okay, next slide, please. Another program that is concerned for compliance reasons would be the uninsured program, HRSA COVID-19 uninsured program. This is more than 3.7 billion has been paid to over 203,000 healthcare providers have enrolled in the program as of February 15, 2021. A lot of money. It's been going out to a lot of providers. Big concern as far as, okay, the providers are getting the money, as far as they will be audited. So it's important to understand, you have documentation to support what the amounts that you receive from HHS. The uninsured definition for claims for COVID testing and related services: a patient is considered uninsured if he does not have coverage through individual or employer-sponsored plan, a federal health care program, or federal employees program. For treatment of positive COVID cases, the COVID-19 case, and patients considered uninsured he didn't have any healthcare coverage at the time the service is rendered. And for claims for vaccination, similar thing at the time the service is rendered. So very important that, that they're not insured. So how are we going to document that? Next slide, please. First, we're going to cover the eligibility. The providers are eligible, healthcare providers are eligible if they conducted COVID-19 testing for uninsured individuals, they provided treatment with a primary COVID-19 diagnosis on or after February 4th, 2020, and they administered a licensed or authorized COVID vaccine to uninsured individuals. Very important here is on or after February 4th, 2020. The providers began enrolling in the program on April 27th, 2020, and claims started on May 6th. Eligible providers will get claims reimbursement through the program electronically at the Medicare rates. So basically, there's been a lot of money spent, paid the providers on this program, and there'll be concern of how you're going to make sure you pass the audit test. Next slide, please. Okay, internal audit should be utilized to test this compliance for this program. Key thing is the provider and patient eligibility. To participate, providers must attest the following at the registration. They check for healthcare coverage eligibility and confirm the patient is uninsured. They verify the patient does not have coverage, such as Medicare, Medicaid, individual employee sponsored plan. Very important, for Medicaid claims, provider may submit claims for reimbursement before Medicaid determination is complete. However, if the provider learns that the individual is retroactively enrolled in Medicaid as of the date of service, provider must return the payment to HRSA. So that's an important thing because Medicaid is eligibility is always constantly changing. So if you've been paid, if the provider has received money on this program and down the road they're retroactively eligible for Medicaid and get paid by Medicaid, you need to go through that and make sure that's not double dipping, as we're going to see here in a minute. You want to make sure that you want the test of the covered services, the consistent COVID-19 services. The treatment is coded consistent with the services provided. You want to make sure that you're not reimbursed by another payer, the same patient, same date of service, double dipping. So, I mean, this will be an area which definitely needs to be looked at as far as from internal audit perspective for compliance. Submitted claims must be complete and final. No interim bills or corrected bills will be accepted, and no balance billing. So very important that there's no billing to these patients. So we need to check your documentation and your billing system and make sure that you've not billed the patient for any of the balances for these uninsured people. Next slide, please. The next area is the new COVID-19 treatments add-on payment, abbreviation NCTAP. This is where allows the hospitals to receive a 20% add-on payment for services provided to COVID-19 patients. So the HHS will increase 20% weighting factor of the discharge diagnosis assigned to the patient with COVID-19. And that these add-on payments will not be considered in the annual adjustments to the DRG weighting factors, and from that perspective. Next slide, please. So which DRGs are eligible? Discharge for an individual diagnosed with COVID-19 will be identified by B97.29. That was occurring on or after January 27th and on or after before March 31st. So very important. You have a window of time between January and March for this. And then they had a COVID-19 diagnosis, U07.1 after April 1st until the end of the public health emergency period. So very important that the coding is accurate. To qualify for this add-on, significant dollars. HHS will be auditing this, so it's very important to keep appropriate documentation in your medical record and your coding is accurate. Next slide, please. So best practice in this area would be internal audit should test compliance for these. You take a sample of these claims that you got an add-on payment for and verify the documentation, the medical record supports diagnosis. The diagnosis on the bill is eligible for the 20% add-on payment, and treatment is coded consistent with services provided. Next slide. Well, just trying to summarize here that the role of internal audit could be used for all three of these programs that we've spoken about: the loss of revenue methodology and calculation, the uninsured program, and the CTAP program. Very important, test these things, make sure they're consistent with the regulations, because you will be audited and HHS will come in and recoup funds if they're not appropriate. Next slide.
Okay, we're on our fourth and final polling question. Providers can receive reimbursement for uninsured patients under the HRSA COVID-19 uninsured program for what type of services? About 15 more seconds. All right, I'm going to close it out. And here are the results.
Well, I think everybody picked it up. That's all the above, 90%. That's great. Yes, you can get reimbursement of all three of those. I'll turn back over to Dominic.
Thanks, Mark. So we're going to take some time now. It looks like we have 6 or 7 questions here, and a few good ones. So the first question we have is, if your provider relief funds were kept in an interest-bearing account, is the interest reportable in terms of revenue? The answer to that is yes. And the second part of that question was, if the money cannot be utilized and is returned, do you have to return the interest portion also? Yes, yes to both. The good news is we're in such a low interest bearing times right now that it's minimal dollars, but there actually is a frequently asked question about that specifically talks about interest earned and if you return those funds. So good question. The second question is the PPP loans considered part of the revenue? And this is a great question. We've had a lot of discussion internally with our PPP group on this. And this really comes down to the point of, if you go through the FAQs, it talks about net patient service revenue, what's included in net patient service revenue. And then it has a definition of other revenue. And it talks about other forms of funds received for the pandemic. So PPP, FEMA, EIDL, other type of funds that are out there. The question really becomes, because HHS doesn't talk in accounting terms, most of our clients who had PPP, who were 1231, did not report this as revenue because it was hung up on the balance sheet as a contingency or as a loan. So we've been advising our clients who are calendar year ends that as of 1231, the PPP is not considered part of the revenue. And the reason because of the question is, when you go to do your lost revenue calculation, that 2020 actual revenue, should that PPP be included or not? I've actually reached out to HHS to get further clarification. Numerous people have. I've been on other webinars where there's some confusion around this. So at this point in time, the way it's accounted for at 1231 should be the way it's reported. If you had accounted for it and you had received forgiveness and it is part of other revenue, then it should be included in your net patient service revenue based on the HHS definition for your lost revenue calculation. And that's a great question. Another question we have, if the funds, all right, so let me understand this. If the funds are received from a corporate entity of a healthcare system, those targeted funds were then redistributed, who reports on the funds received? So I think what's being asked here is, and I gave an example of it before, if let's say you're a large healthcare system and the funds are being received by the corporate entity, and some of those funds came in through a targeted distribution. If you reallocated those funds, which you now can do, to other entities within your system, and those other entities have separate TINs, the entity who received those funds do not report those funds. It is the reporting entity that received the funds who has to report on those, irregardless of where the funds end up. And I think it was January 28th where FAQs came out and there's numerous ones to discuss that. And one last question on the Consolidation Appropriations Act and the 85%. Can you further clarify what the 85% means in terms of Q3, Q4 losses? So we can give a little more guidance. Again, the language is in the Consolidated Appropriations Act that states it will mirror phase 3. So again, phase 3, you had to report your Q1, Q2 data. They then took that and calculated the losses because you submitted revenue and expense. Consolidated Appropriations Act, what they're saying is it would be Q3, Q4 data that will be requested when it's opened up for reporting, and 85% of those potential losses. So again, if your losses for Q3, Q4 were $1 million, the funds you could get up to $850,000. That's how the language is written. We don't know how the House and Senate and Congress will push it through, but two things we do know. One, there's $24 billion of unspent provider relief funds, another $3 billion in the Consolidated Appropriations Act, that's 27, and the language is in the bill to allow for this to happen. So great question. That is the last of our questions. I'll just take the last 5 minutes here just to give an update on what we're hearing from the latest stimulus bill. I know the House had voted and approved it, and now it's going to walk its way through. A lot of lobbying groups, AHA, many of them are pushing for this additional $30 billion of provider relief funds. I think I stated this before, interestingly enough, there was $34 billion as of December 31st. Now the number's $24 billion, so I'm not sure, but a big push for that. Again, we talked about the partial forgiveness of Medicare loans. The language was in, and at the last minute was taken out of the last bill, the Consolidated Appropriations Act, and that was up to 40%. Again, $100 billion of loans that are put out there. Clearly the concern is with costs continuing to go up, staff costs, supply costs, volume continue to stay where it's at a low point, margin pressures out there, the provider relief funds will be basically used, and then all of a sudden you have to start paying back $100 billion in loans. So it clearly has the attention. If there's another stimulus package after this, if it doesn't make this one, there's a big push from all lobbying groups to continue to push on this. And, you know, I think, and everyone has read this, the biggest of dollar amounts in the current bill that's going through the House right now is around vaccination and around the COVID-19 testing. There are also some positives around Medicaid expansion for those 13 states. Doesn't impact us as much here in the Northeast. And there could be some improvement in the federal match. So the federal government could put a greater match to the Medicaid dollars for each state, which would increase the Medicaid dollars available for all providers in the states. So that's just a little bit of an update. More to come as language starts to come out. And again, very confusing, a lot of information here. Takeaway is look at the provider relief FAQs. Marc did a great job. Absolutely, the government's going to come back and take a look at $2.4 billion in uninsured. You need to make sure from a compliance and from an internal audit standpoint that you don't have patients that all of a sudden now have insurance, or you got paid after you were paid that Medicare reimbursement from an uninsured standpoint. We think even more so than the 20% add-on and the lost revenue calculation, we think the uninsured is really going to be a focus of where they will come back to look at. So we thank you for your time today. I'll open it up if there's any more questions out there. And it looks like there's no more questions, Rachel. So thank you everyone for your time, and have a great evening. Thank you.
Sorry, Dominic, there's just a couple more questions I'm seeing, and I just want to make sure that everyone stays on for 50 minutes in order to receive CPE credit. It looks like another question that has been, will HHS send a request to report and document expenditure of funds received by 7/31/21, or must a recipient go to the portal to request this?
So that's a great question, and what we're understanding is the portal and the importance of registering for the portal. That is where HHS is going to distribute the information for template, if you will, the template and the reporting timeline for those funds. So again, very important, make sure you register in the portal, make sure it's an email of the person or people who are going to be doing this. All of the information will flow through that portal.
Thank you. Where's the link to the portal?
So if you actually, and apologize, we should have put that in here. If you go to the post payment notice, so if you Google post payment notice 11521, and I'm not sure if I included a hyperlink here, in that post payment notice, they have exactly where to go, and they have the link, a hyperlink for the portal. And it's pretty straightforward. You know, your EIN number, your Medicare provider number, basic information, takes about 15 to 20 minutes.
Great, thank you. And another question, we will be distributing this recording and the slides as well to everyone that registered.
Yes, and you have my email, I believe, is included there. Please, any questions, feel free to reach out. Again, ever-changing, very confusing. Everyone has a day job, and trying to keep track of this on top of it makes for very difficult. So reach out, we're happy to help in any way we can.
All right, thank you, everyone.
Thank you, have a great day.